start discussing about the neurology recall sessions 2023 NEET. So coming to the question paper, there are actually in fact a good fair number of questions came from neurology, and I had included some of the topics are not neurology. Some two questions are from psychiatry actually, and that is not relation to neurology. There are few questions which are combined, like they have some involvement. They may be covered in infection as well as in neurology, but predominantly there are 23 questions which are predominantly neurological questions which I could collect. That is 28 questions. And see, first of all, I want to tell you that any recall, this is not the exact questions. This is something we got from multiple sources, and we did a Zoom call, a Zoom video conference to get the proper questions. Then also we had some confusion regarding the option. So this may not be the exact questions. And coming to the question, coming to the pattern of the NEET this time for neurology part, there has been a difference from the previous pattern. There are some unexpected areas questions kept on asked from, like particularly from pain area. There are few questions coming from that area only, and the majority of the questions were not complicated. That like usual pattern of clinical scenarios or usual pattern of questions in the stroke. All those things are not there. Actually, in fact, there is no question in the stroke area. So that is what every year, if you take the last two recalls, the third recall, last three recalls, if you take, there is lot of difference in the pattern of questions. So you cannot expect a similar pattern every time, but altogether your basic knowledge will help to answer these questions. So we'll go to the questions. This is the first question, that is which of the following is central area of sensitization of pain? That is, initially I got the question as central area of sensation or central perception of the pain was first question I got. Then it has been corrected by some of my students, and it is central area for sensitization of the pain. So what is pain sensitization? Pain sensitization is a phenomena by which the recurrent or chronic pain, the body become more available for the pain, or the body sense the pain even with a slow threshold and a severe pattern. If a non-noxious stimulus can produce a pain, that sort of exacerbation of the pain experience, that is known as a sensitization. That happens basically in the peripheral as well as central area. And if you take Harrison, one sentence is given that central sensitization of the pain happens in the dorsal root ganglion. So actually, in fact, the pain sensitization or the neuronal plasticity to the chronic pain, that is known as neuronal plasticity to the chronic pain. There's a modulation or modification of the chronic pain happen. The recurrent pain happen. If you have a radiculopathy, slowly what happens is if you touch in that area, he will get a pain. Even without touching, the pain will increase. That means the threshold for the stimulus has decreased. So that is known as sensitization. That is known as neuronal plasticity. This is on the Bradley. And they have three steps: activation, modulation, modification. If you see, this side is a peripheral system and this side is a central areas. The central area predominantly happens in the dorsal root ganglion. The activation of the initial process, which is reversible. There is not much needed. Details are not required. But I just tell you because this question has come up. Next time some question may come from this area. That is why I just try to cover that area. So this is activation is a reversible process, that is initial process. And then you have the modulation, and then you have the modification. There are three steps: activation, modulation, modification. These are the neuronal plasticity by which the body became more sensitized to the pain. So activation can happen in the peripheral area as well as the central area. When it happens in the peripheral area, that is known as autosensitization. This happens, the peripheral happens in the peripheral receptors. Peripheral receptors. The central happens in the dorsal root ganglion, predominantly the dorsal root ganglion. This is because of the protein conformational change. Because of repeated stimulus, there is a protein conformational changes are happening. Conformational changes happening, that is responsible for the activation. They had autosensitization wind-up phenomena. Wind-up phenomena is happening at the dorsal root ganglion. That is because of, again, because you remember we were discussing in the learning module, the memory module, we discussed about long-term potentiation and long-term depression, which is a synaptic process of plasticity. Same mechanism happens here. Because of recurrent stimulation, you have glutamate. Glutamate has three types of receptors. It has NMDA, not three, it has two types, metabotrophic and non-metabotrophic. One group is NMDA, kainate and AMBA. Okay, kainate and AMBA, which we have discussed. Again, this is important in epilepsy drugs. We have used it. So of this, just take over the kainate. Remember about NMDA and AMBA. The NMDA has a calcium channel, while AMBA is a sodium and potassium channel. Normally, the calcium channel of NMDA is blocked by magnesium. When recurrent stimulation happens, this calcium channel open up and the calcium goes in because magnesium is removed. So, recurrent pain stimulation, magnesium is removed, NMDA channel open, calcium goes in. When calcium goes inside the cell, there's lot of changes happens to dorsal ganglia. Like there will be some protein kinase activation, new protein production, hyperactivated the reflexes will receptors will come. All those things we have discussed in memory module. Ultimately, what happens is a glutamate mediated, the NMDA mediated calcium influx, and which causes exacerbation of pain. This is just like your long-term potentiation of synaptic plasticity, that is known as a wind-up phenomena. But these two, peripheral as well as central, wind-up and autosensitization, are reversible process. Then modulation is where the question came, that is from the sensitization area. The modulation has heterosensitization and central sensitization. Heterosensitization happens again in the peripheral receptors, while central sensitization happens in the dorsal root ganglion. This heterosensitization, this is because of phosphorylation of protein. Phosphorylation of protein. The first one was protein conformational changes, but this one is phosphorylation of the protein. It's much more long-lasting pain. This is reversible, but it is long-lasting. Okay, so central sensitization happens in DRG, dorsal root ganglion region, because of phosphorylation, and your pain became more sensitized. Heterosensitization happens in the peripheral, and the modifications of final and chronic process where the change happens at the genetic level. This happened again central as well as peripheral. Central is again in the dorsal root ganglion predominantly, and some of the cortical fibers or the upgoing fibers also changes will happen. Your A delta, C delta fibers also changes. So that is much more complex process. So just remember, neuronal plasticity of pain or includes one is activation, modulation, modification. Modulation is otherwise known as sensitization, where you have central and peripheral. Almost all central process happens in dorsal root ganglia, while the peripheral happens at the peripheral receptor level. So central area of sensitization, just directly given, one sentence is given, not in details. One sentence is given Harrison. That is central sensitization happens in DRG. This is also same thing, which is given the Bradley or any textbook if you refer. That is a process of neuronal plasticity to pain. That is how your chronic pains, like your trigeminal neuralgia, chronic migraine, or even your sympathetic dystrophy, that is your complex regional pain syndrome. These all things happens because of the neuronal plasticity. One mechanism of neuronal plasticity is central sensitization, which happens in the dorsal ganglion. So the better answer is spinal cord, because the dorsal ganglion is situated inside near spinal cord. I don't know what are the exact options asked here, but this is the answer for that. The ideal answer is DRG. I don't know. I'm not sure whether DRG was given in the option. If DRG is given in the option, that is answer. If that is not given, among the following, the best answer goes to spinal cord. That is what my inference is. There may be a difference in opinion, because I don't know the exact options and I don't know the exact question. This was a almost nearby question. That is why I want to discuss the entire area. Okay, if I know the exact question, I won't go into such detailed discussion. Okay, so coming to the next question, the placebo effect of the pain is mediated at what level? Again, there is a confusion regarding the options. Some told cortex is there in the option, while in Zoom discussion, some told thalamus was there in the discussion, some told some thalamocortical flow. Let us discuss the topic rather than go into the option, because I don't know exactly what option is given. So this is something which is given a figure in Harrison, but this is quite commonly discussed in other areas. Like this is when you give a placebo drug that will produce some analgesia. That is because the cortical modulation of the pain pathway. Because this placebo effect is a neuropsychiatric or psychiatric modulation, psychosomatic modulation. If they ask the pathway at what level, it is not psychosomatic modulation. It is a level or a pathway at which it is happening. This is happening at the cortex. Predominantly, these are the areas involved. These are the periaqueductal gray, your hypothalamus, periaqueductal gray, and the rostroventral part of the medulla, and dorsolateral prefrontal cortex. This is the dorsolateral prefrontal cortex, and this is your rostral anterior part of the anterior cingulum. Again, these two form the part of frontal lobe. Okay, dorsolateral prefrontal cortex, anterior cingulum. I had discussed during the module that these are the areas. Frontal lobe is the area of limbic system. Pain and emotion is pursued predominantly in the limbic system. So again, the areas are the same areas of limbic system. Hypothalamus, that is also a major area of limbic system. And in here, periaqueductal gray and rostral ventral medial nucleus to the medulla. RVM, rostroventral medial nucleus, and hypothalamus. Sorry, this is not hypothalamus. This is periaqueductal gray. and this is hypothalamus. Okay, and this is rostroventral-medial nucleus of these are the areas concerned with placebo analgesia. So it has brainstem structures and it has cortical structures, of which the major part is actually the cortical structures. There was, as much as I know, there was no option like brainstem. Actually, it has areas of brainstem like medulla, as well as other areas involving the cortex. So I feel if cortex was there in the option, that is the best possible answer. But this mechanism is not only happening at this level. It has some thalamic activation, thalamic inhibition, thalamic activation also. So that is why if thalamus was there, that is also an option. You should answer depending upon what is the option. We will see the subject, what is happening. So you can see that this whatever given, these are the areas concerned the pain, and these red lines are the ascending pain. The pain is ascending from here, and these green lines are the descending pathways which inhibit this pain or descending pathways. So you can see that there is blue things are increased activation. So these are increased activation of prefrontal cortex, dorsolateral prefrontal cortex, and some part of the nucleus accumbens, which we have discussed in our module. I'm not going into details of that here. That we have discussed multiple times in the Parkinson's as well as in dementia. And there has been some inhibition of the areas of medial thalamus. That red thing is where the pink or red thing is where the decreased activation. And these periapical gate and also RVM of the spinal cord and medulla are these RVM and spinal cord where you have either increased or decreased activation. These are the areas involved with neuropsychological effect of the placebo effect on pain. So you can see that medial thalamic nucleus is involved. So even though thalamus is not a major part, some part of the medial thalamic nucleus, which forms part of the limbic system again, are also can be involved, can be connected to the placebo. But as much as I got from the majority of students, thalamus was not there in the option, cortex was there in the option. So if cortex is there, placebo effect is mediated through cortex. That is in fact not only cortex, it is predominantly frontal lobe, that is dorsal prefrontal and your anterior cingulum, plus some areas of hypothalamus, some areas of the periapical gray, and some areas of RVM and spinal cord, plus minus medial thalamus. So that is what is placebo effect of pain. I discussed it again because it's a new topic, and there is a lot of confusion regarding the question. So next was a clinical scenario was given, a 42-year-old male patient who has chorea, dystonia and depression, and they given it is a slowly progressive process, and they are given a family history of anticipation. I don't know exactly what is the statement, but this was what is given. So anticipation in family history means repeat disorder. So it is a repeat disorder. That tells you that a repeat disorder. And you can see that depression, psychiatric depression is there, and chorea is there, and dystonia is there. Very clear answer. The answer is Huntington's chorea. I don't know the other option. Sydenham's chorea will not have family. Sydenham's chorea is secondary to RSD. And depression, dystonia, chorea, psychiatric plus movement disorder in a young male or an old age, psychiatric plus violent movement disorders and extrapyramidal, you should think of Huntington's chorea. Okay. So that is the answer for that. The next question is also very simple. Patient has history of fever, diarrhea, later developed oculomasticatory myoclonus. Something like that they are given. Whether they are given myoclonus or myorhythmia, I am not sure. Actually, it is not oculomasticatory myoclonus. It should be myorhythmia, which we have discussed in our module. We discussed it twice. First we discussed it in cerebellum also, and again we discussed somewhere in the movement disorder session also. Oculomasticatory myorhythmia is a classical movement disorder which is seen in Whipple's. So Whipple's present with GI involvement, arthritis, some may have dementia, psychiatric symptoms, seizures, cognitive impairment, and human motor signs, myoclonus. All those things are part and parcel of Tripharma Whipple. So the options which is given here is, it's not Treponema pallidum, it was Tripharma Whipple. This is the wrong thing. It was given as Whipple. Tripharma Whipple was given. This actually whatever in the print, there's an error in the slide. So the answer was Tripharma Whipple was the answer, because the classical movement disorder which we have discussed, oculomasticatory myorhythmia and oculofacial skeletal myorhythmia, is a classical movement disorder which is seen in Tripharma Whipple. It is not explained in other conditions classically. So that itself is a diagnosis. You just see that supranuclear gaze palsy is also there. I remember some students told that was there in the question option. That make it more clear, because Tripharma Whipple or Whipple's disease is a DD for your PSP, progressive supranuclear palsy. Okay, PSP, Niemann-Pick C and Whipple's disease, these two are DDs. We have discussed it again in our module on PSP also. So the answer is Tripharma Whipple or Whipple's disease answer. The next question is, they are given a patient diagnosed with Wilson's disease, develop hypertonia, rigidity after treating with levosulfurate, and they are given some angle clonus or something, and which of the following is a mechanism led to this feature? So this is very clear. This is very easy question. Anyone can answer it. Levosulfurate is notorious for causing movement disorders, particularly peripheral dyskinesias, and this is classically because of dopamine receptor blockade. That is also very easy and straightforward question. There's nothing to think in that. Which anti-epileptic drug causes weight loss? Again, there is a confusion options. Some told topiramate was not there in the option. Some of the students told that topiramate and sonisamate both were in the option. Anyway, lamotrigine and phenytoin is not the answer. Topiramate is a drug which is used for weight loss in other ways also. Like a patient with migraine with weight gain, you give topiramate because topiramate has affected migraine as well as in the weight gain. And if a patient had want to get weight loss also, you can get topiramate. And in epilepsy patients, especially females with obesity, you can give topiramate. So topiramate is the answer if both are there. If suppose the option topiramate is not there, then you can go with sonisamate. If you compare topiramate and sonisamate, topiramate is a better potent weight loss and sonisamate is much lesser, but it also causes weight loss. So we have discussed about the side effect of topiramate and sonisamate in our module where you discuss about the drug side effect. I had repeatedly told anti-epileptic drug side effects are very, very, very important. So it causes weight loss and kidney stone in 1.5%. Kidney stone is much more in the case of sonisamate, approximately around 4% in sonisamate. And weight loss, sonisamate also causes some amount of weight loss. So that is there with sonisamate also. Remember that causes angle closure glaucoma. That is another question which is coming in next question. Topiramate causes angle closure glaucoma and myopia. Hyperammonemia when used with valproate. Valproate itself causes hyperammonemia. When you use topiramate with valproate, hyperammonemia is high risk. Then coming to sonisamate, it causes weight loss again. So that is why I told you can answer sonisamate or topiramate. If both are there, topiramate is the first answer. If only sonisamate is there, you go with sonisamate. Anti-epileptic drug which causes angle closure glaucoma, we just discussed, that is again topiramate. Sonisamate, that is not classically described. So even though both are almost similarly acting, not classically described. So the answer is topiramate. Phenytoin doesn't cause, levetiracetam doesn't cause. Another drug which causes angle closure glaucoma quite frequently used in neurology is amitriptyline. That can cause. Okay. Tricyclic antidepressants can cause. Again, this is another confusing question. I am not sure what was option given in the last one. Some told magnesium, some told calcium. And I will give you the reference also which I got from Bradley, which is higher in CSF than in plasma. Remember, sodium chloride, protein and magnesium, these are higher in CSF than plasma. While calcium, bicarbonate and glucose, these are low in CSF. So I think it was option given was calcium. If magnesium and sodium is given, I will go for sodium only because that is something is definitely given in all textbook. But Bradley has given that see higher level of sodium, chloride, magnesium and lower level of potassium, calcium, bicarbonate, glucose is found in CSF than expected from ultrafiltrate. So higher level of sodium, chloride, magnesium is the and I mean what I told is wrong actually. So not protein, sodium, chloride and magnesium. Okay. So lower level of glucose, calcium and bicarbonate. So potassium, calcium, bicarbonate and glucose. So it is potassium, calcium, bicarbonate and glucose is low. Okay. Sodium, chloride, magnesium is on the higher side in CSF. So I think what I got from majority of students is that some tell that in the option, some told that in the options calcium was there. Some told that in the option magnesium was there. Whatever the answer, I feel it should be sodium. The female on vitamin supplementation, this is also a tricky question. Female on multiple vitamin supplementation, complaining of symptoms, they told some tingling, numbness or something like in the distal lower limb, suggestive of peripheral neuropathies. So vitamin A toxicity, vitamin D toxicity, hypervitamin, vitamin B6, vitamin E toxicity. Again, pyridoxine toxicity is known to produce sensory neuropathies. So it has nothing to do with myelopathy. So hypervitaminosis produces peripheral neuropathy. Vitamin B6. Vitamin A toxicity has nothing to do with neurology. It causes fat soluble vitamin. And vitamin D also is a fat soluble that doesn't cause much neurological symptoms, but they can cause aches and pains. And vitamin E toxicity, if vitamin E deficiency can present with myelopathy, myeloneuropathies, subacute combined degeneration. By hypervitaminosis, B6 is the answer, which causes peripheral neuropathy. Okay. So coming to next question, which among the following is non-sedative anxiolytic? This is not a neurological question. Even though we neurologists use these drugs are not more used by physicians and almost everyone uses it right and left. Anxiolytics is something which is very out of the box, I'm telling you. Anxiolytics is one group of drug which is grossly prescribed unnecessarily from MBBS level to higher. Whatever symptoms, if you cannot localize, you give an anxiolytic. That has become a practice in many places. That is not correct. But we'll come back to the question. Chlordiazepoxide, buspirone, clonazepam, temazepam. All benzodiazepines are sedatives. The only non-benzodiazepine drug is buspirone. So the answer is anxiolytic, which is non-sedative, is buspirone. This is a table from Harrison: diazepam, flurazepam, triazolam, alprazolam, chlordiazepoxide, and all these things are there. Buspirone is even that non-sedating drug. Okay, this is non-benzodiazepine. So that is the answer for that question. Coming to the next question: what are the adverse effects of clozapine? Again, it is not a neurological question, either medicine or psychiatric question. And you all know that clozapine is a drug which is given for movement disorder, especially drug-induced dyskinesias in a Parkinson, in a psychiatric patient. Only drug you can safely give is a clozapine. You withdraw the drug and start with clozapine. If your drug-induced movement disorder which is not controlled, and you want to give treatment for psychiatry, go with clozapine. Clozapine is safe in all the way, but clozapine causes severe pancytopenia. That is why nowadays majority used to give quetiapine instead of clozapine. Quetiapine also, the dopaminergic blockade or the side effect because of movement disorders are much lesser than many other antipsychotic and doesn't have much side effect like clozapine. Like pancytopenia, severe pancytopenia is not seen with that. That is why I used to prefer with clozapine. So the answer is pancytopenia. The next question, again, it is a very, very tricky question: migraine treatment during lactation. If you come to migraine treatment, you know that all these drugs are used in migraine treatment. Okay. So the migraine treatment in pregnancy, what will you give? Pregnancy, you cannot give any drugs for prophylaxis unless risk benefit is beneficial. So majority almost every patient with migraine in a pregnant lady, better not to give prophylactic agents. None of the drug is 100% safe. If at all you want to give, you can give is beta blocker you can give, tricyclic antidepressants you can give. And if you use a common sense, the answer is very clear. If you want to see which one of the following is safe, which among the given options is safe, you know that there are postpartum depression is there. So antidepressants are quite frequently given in postpartum and prepartum ladies for postpartum depression. So amitriptyline should be safer during lactation. That is why they used to prescribe that. That is one option you can think. So pregnancy, you cannot give any drug. Then coming to lactation. What about lactation? Lactation, the problem is majority of the drugs will secrete into the breast milk. So the best drug is beta blocker, particularly propranolol, is the best drug for a migraine prophylaxis in lactation. But beta blocker is not there. So what will you give? Flunarizine is not proven. It is not even approved by FDA. So you cannot think of flunarizine. Flunarizine secretion is there in the milk and a child can get sedated. It is not absolutely contraindicated at all, but there is studies are lacking. The amount of studies are lacking. And sodium valproate, again, that is not that safer. You can have a secretion in the milk, so not that safer. And all reproductive age group female, we preferably don't give sodium valproate. And verapamil is relatively safe. So confusion remains between amitriptyline and verapamil. But you see that we have discussed in our module, we had given this table in our module, where you can see the American Society of Headache has classified level A, level B, level C, level U medications. The verapamil is not even in the level B. Level A contains antiepileptic divalproate, sodium valproate, topiramate, metoprolol, propranolol, timolol, and fluvatriptan. Amitriptyline comes in the level 2, but there is amitriptyline in the level 2, that is level B. But you see the calcium blockers are here in the level U, where you have inadequate or conflicting data for support of use of medication. So you don't have a proper data for giving verapamil for migraine. Leave or leave that patient is pregnant or lactating or whatever. You don't have enough data to tell that verapamil is a good drug for migraine. Leave the side effect also, everything you leave. It is level U. So among the option, level B drug you have is amitriptyline. But beta blocker is a level A drug, and particularly propranolol is a level, metoprolol and propranolol, and sodium valproate a level A drug, and it is safer in lactation. So, and again, American Society of Headache Society also recommends that the first choice is a beta blocker. If not possible, tricyclic antidepressants can be given in lactation. So now coming to the next question, MM and CB. what is the treatment of choice? This we have discussed. MMCB is a drug disease of M. Multifocal motor neuropathy with conduction block, a disease of M. Middle age, around 40 years. Male, affecting median nerve. IgM, GM1 ganglioside antibody, and the drug of choice is IVIG or immunoglobulin. Immunoglobulin is a drug of choice. Plasmaxine is not proven. Steroid can sometimes worsen MMCB. Azathioprine is never studied, never given. So the answer is IVIG. So that is very direct question, very easy question. Next question, there is something which is we have discussed. I have discussed it twice. Once I discussed in trigeminal nerve, which is recently added before your NEET SS, where I have discussed numb cheek, numb chin, and numb cheek limb syndrome and trumpet players neuropathy. All 4 peripheral nerve branches involved I discussed, because I hope that some question may come from this area. This is very, very important syndrome in neurology. A numb chin syndrome or Rogers sign, where you have a numbness over the lower lip and the chin area. That area you have numbness is known as numb chin syndrome. Well, numb cheek syndrome is where you have cheek and upper lip area involvement. And numb cheek limb lid syndrome. I'll show it. Numb cheek syndrome, numb chin syndrome, numb cheek limb lower lip syndrome, and leave this syndrome. That is nothing related to malignancy, but leave this. A trumpet players neuropathy. Numb cheek syndrome is where you have infraorbital nerve, where you have the infraorbital nerve which comes from the foramen here, inferior or infraorbital foramen lesion. There is a malignancy, squamous cell carcinoma intruding into this area. The nerve coming out will be affected. That produces numbness over the cheek and the upper lip, sometimes upper gum also. That is known as numb cheek syndrome. The question asked is numb chin. So numb chin syndrome is where a mental nerve or the mental foramen inside your mandible is infiltrated by tumors. Most likely because of a solid tumor malignancies like carcinoma bust, lung, or even lymphoproteic malignancies, the mental foramen is involved. You will get a numbness of the lower lip and the chin area. This is very important because sometimes patient comes to your OPD with this numbness of this area persisting for few days or few months. And you evaluate everything, CT, MRI, everything is normal. You give some drug and the patient won't respond. Sometimes may respond also, but again comes back to you. But if such a syndrome is there, you should evaluate for the primary malignancy. You should take an MRI brain, not only the brain, you should take a facial cuts, including the mandible. Maybe sometimes you request a CT cut also along with that to see that whether the mandible is invaded with a malignant tumor. So that is known as numb cheek, numb chin. What is numb cheek limb, lower limb? Numb cheek is inferior orbital foramen, inferior orbital nerve is involved. If the tumor has progressed and involved the facial nerve, you will have numbness along with the lip. This area is paralyzed because the branch of facial nerve is involved. That is known as numb cheek limb, lower limb syndrome. So this is numb chin syndrome or Rogers, mental or inferior alveolar nerve. It is related to malignancy. It is very, very, very important. If such a patient comes to such a syndrome, you should always search for a malignancy, because numb chin is more associated with systemic malignancies, but numb cheek is more associated with local squamous cell carcinoma. So numb chin is more important, because numb chin you may not find a malignancy here. It will be somewhere. You have to do a PET scan. Sometimes you have to do a PET scan. Sometimes you have to evaluate for the malignancies. Numb cheek limb, lower limb is very infraorbital nerve involved in the distal facial nerve. And trumpet players neuropathy is somebody who is a trumpet player. You have pain and numbness of upper lip because of anterior superior alveolar nerve involvement. There is a different entity. So the answer here is a neoplastic entity. Okay, numb cheek syndrome is associated with neoplastic entity. Next question is antibiotics not precipitating myasthenia gravis. That is actually a very easy question. And this is a very straightforward question, one-liner question. Aminoglycoside, fluoroquinolones, macrolides, and telithromycin. These are drugs which worsens, antibiotics which can worsen myasthenia. Aminoglycoside, telithromycins, fluoroquinolones. So, macrolides. These all will causes worsening. The answer is cephalosporins, which is quite commonly used in myasthenia patient with respiratory infections. It's quite common phenomena, like seen things is respiratory infection myasthenia patients. That can worsen myasthenia because of infection, not because of drugs. So this is some table which I had given in the module. Beta blockers, statins, procainamides, chloroquine, HCQ, Botox, desferoxamine, corticosteroids, immune checkpoint inhibitors, iodine contrast, magnesium, all these can worsen. See, one thing important you have to remember is corticosteroids, which is used in treatment of myasthenia. Particularly in myasthenia crisis, when you give IV methylprednisolone, you can have a worsening initially, then later it may improve also. But that worsening is usually covered in such scenario by giving plasma exchange along with the IVAG or along with the corticosteroid, or IVAG along with corticosteroid. So corticosteroid induced paradoxical worsening is also seen in myasthenia. But the answer here is These macrolides, fluorochemical, these three were the option. Answer here is cephalosporins. So next question is opioid uncommon side effect. Again, this is don't think too much. It's a very easy thing. Opioids are well known for physical dependence and tolerance. Somebody was selling in somewhere and Harrison it is given like that, or whatever it is given. Opioids are well known for its physical dependence and tolerance. Addiction also is there with opioids, quite common. That is, opioids, many of the opioids are you cannot prescribe that easily. And coming to hyperalgia, normally opioids are given for treatment of pain, but sometimes paradoxical and chronic opioid therapy, you can develop paradoxical opioid-induced hyperalgia. It is very uncommon, but that is the answer of this question. That hyperalgia exact mechanism is not known. Some alteration in the pain pathways where opioids act is supposed to be a mechanism, but it develops a confusion of hyperalgia between tolerance, because in tolerance, when you use repeated opioid dose, initial sign what you see in a tolerance is the duration of the effect comes down in tolerance and patient requires more dose for this. Similarly, here also you will see initially you may see that either duration comes down or the pain started coming early. That is sometimes difficult to differentiate. That is known as opioid-induced hyperalgias. That is an uncommon side effect. That is the answer for that. Next question is actually the only question which is asked from demyelination, but it is very easy question. 30-year-old male lady present internuclear ophthalmoplegia who was treated for optic neuritis before investigation of diagnosis. Again, optic neuritis means previously treated. So that means old history of optic neuritis, that increased risk of MS, which we had discussed. And internuclear ophthalmoplegia, which means it is a brainstem involvement. There is two sites are there. Investigation for diagnosis, not VEP, because it is not an acute episode of optic neuritis. VAP is not used for diagnosis of disease, but it can diagnose optic neuritis, that's all. Disease is actually multiple sclerosis. You need an MRI brain to look for the other areas, classical MRI signs of multiple sclerosis, and spine and the brain to look out for DAS, dissemination space and dissemination time. You can localize by using your MRI. So the answer is MRI brain and spine should be done. Okay, that much is clear. Next question is impulsive petit mal. This is again I feel it is not a good question. Actually, these classification, petit mal, which is a little disease or little fear, that things are way age-old entities. That is not at all used since years, maybe in century, maybe in decades. This is the oldest name. So petit mal is a focal seizure. Impulsive petit mal was or Jan's syndrome. These are other names of juvenile myoclonic epilepsy. Because of the jerky myoclonus involved in the shoulder, it was initially called as petit mal. Because petit mal was initial name given for complex partial seizures, the initial phenomenon of staring look and all, they will call it as petit mal initially. So this is impulsive petit mal is another name for JME. This is something if you know, you can answer. If you don't know, you cannot answer. The answer is JME. JME other name is Jan's syndrome and impulsive petit mal. And these questions are actually very not at all useless question, I will say, because this question, knowing this, you are not getting any benefit basically, because this is something which is not used nowadays. Who is going to call a patient as petit mal or impulsive petit mal? Nothing like that. It's not there. But still, for the for entrance, we can ask all those sort of questions, and the answer is juvenile myoclonic epilepsy. Other names are Jan's syndrome and impulsive petit mal. So next question is question number 19. A 48-year-old patient who is a carpenter by profession. This is also again a very tricky question. Carpenter by profession presents with tremors involving head, voice, this is important, head, voice, tongue, and impairment of activities like drinking. Okay, impairment of activities like drinking. There is a family history of similar complaints, and patient is able to perform activities if he concentrates for the same, and the diagnosis. Okay, so this essential tremor has a bimodal peak from 30 years above and 60 years. There are two peaks you can see. The age is doesn't falls in the criteria for diagnosing essential tremor. Whatever you tell essential tremor, we had seen hundreds of essential tremor not in this age group also. And essential tremor is one entity. Till now we don't know whether it is a pure ET only, or whether it is some pathology is growing inside the brain, because many of the ET patients sometimes they may develop, I had seen some patients, they may develop some other signs and later may develop Parkinsonian also. So Parkinsonian features also. So that is why the entity called as ET plus has come up. Again, the understanding of ET plus or even the existence of ET plus is again a questionable entity. So we will leave all those things. Just come back to the question. There is a head tremor. I had discussed in our module whenever the patient is having head tremor, your diagnosis is very less. Head tremor, you have only very few diagnoses. One is dystonic tremor and second is ET or essential tremor. Clear? So either a dystonic tremor or ET tremor. Then he has a voice tremor. Voice tremor is typically seen in essential tremor. Voice tremor is not a feature of Parkinson's. Sometimes you can get dysphonias in laryngeal spasms and dysphonias associated with breathing difficulties in dystonia, in a generalized dystonia. But when the patient has tremor means it is involved in the hand. You can see that it is involved in the hand. And if that tremor, if you consider as a dystonic, suppose a confusion happened between the dystonic and essential. If you consider that tremor which is happening here is a postural component. A postural component can sometimes be dystonic also. If dystonic postural component with a head tremor and with a voice tremor, it cannot be an isolated dystonia. It should be a syndrome or it should be a generalized dystonic syndrome. So in such a patient, you won't see him working as a carpenter, you will see him difficulty in walking, he will not be doing any activities, and he will have, when you have voice tremor in dystonia, that is actually not a voice tremor, this is because of laryngeal spasms, they will have breathing difficulties, they will have stridors. So those things are not there. This is a very benign thing what they are given in the history. A carpenter, because he requires very fine activity, he is able to do it. He has a head tremor, voice tremor and tongue tremor. Tongue tremor occurs in ET. And impairment of activities like drinking, because ET, the tremor will be more while doing fine activities, holding the glass, drinking water, when reaching the face the tremor will worsen. So it's a classical phenomena of a essential tremor. There is no confusion at all, should be there. So the answer is essential tremor. The confusion when we had discussion with students was a dystonic tremor. It's never a dystonic tremor from the question whatever it is available, because to have a head tremor with a laryngeal dystonia, with a hand tremor, the patient should have severe dystonia of the whole limbs and he will not be unable to walk also. That much severe dystonia should be there. So it is not a dystonic tremor, it is a very benign thing they are telling. He's a carpenter, he's 48-year-old, having a head tremor, having a voice tremor. That voice tremor is a cue, even tongue tremor is a cue. These two things are classically telling that it's essential tremor, and I feel the best answer here is essential tremor. Patient on treatment with fluoxetine present with recurrent thunderclap headache and angle clonus. MRI showed vasogenic edema in the parietal and occipital region. BP, I am not sure whether BP is given or not. Even if BP is not given, the answer doesn't change. So we will leave that BP thing. Patient on fluoxetine, that is very important, present with a recurrent thunderclap headache. So what, just take the symptoms there. When you analyze a question, if there's a clinical question, take the symptoms and take the cues. So he is on fluoxetine, that's the first cue. Second is thunderclap headache. So what are the causes of thunderclap headache? When the patient comes to you with a thunderclap headache, I had explained multiple times, thunderclap headache, you think of RCVS, you think of SAH, subarachnoid hemorrhage. Then you think of SCVT. Then you can sometimes also occurs in older age group with a metastatic lesion. But classically, these are three things you should consider when you have a thunderclap headache. Or the fourth one is a idiopathic or a primary thunderclap, where you don't know the exact mechanism. And if you take the etiologies of thunderclap headache, if everything is ruled out, even migraine can cause thunderclap headache, and like because of RCVS. So RCVS, or reversible cerebral vasoconstriction syndrome, they present with thunderclap headache, and this RCVS come under a spectrum of hypertensive encephalopathy. Hypertensive encephalopathy, RCVS and PRES both comes in the spectrum of hypertensive encephalopathy. RCVS, because of it can cause stroke, it can cause cortical SAH, it can cause vasospasm. So the next part of the question, they are telling that the patient had a vasogenic edema in the parietal and occipital region. What is that? Vasogenic edema in the parieto-occipital region. Vasogenic edema means it is not a cytotoxic edema. Cytotoxic edema is seen in MRI as diffusion restriction. Vasogenic edema, there is no diffusion restriction, but vasogenic edema is seen in FLAIR and T2. So vasogenic edema means this is classical PRES they are telling. Posterior reversible encephalopathy syndrome, classical image. You don't have a diffusion restriction, you will see FLAIR hyperintensity in the parieto-occipital area. This is something which they are telling is a PRES. So there is a PRES and patient is on fluoxetine. For RCVS, it hypertension, axial hypertension is one etiology. Second is drugs, particularly antipsychotics and tricyclic antidepressants and SSRIs and SNRIs. These are the drugs which produce class, and some of the chemotherapeutic agents. These are drugs which produce PRES, RCVS spectrum. So, and even if they are not given the BP, the answer is reversible cerebral vasoconstriction syndrome. Why it is not SH? They are not given an SH in MRI. That is a simple answer. NMS, they are given some angle corners to confuse you with NMS, but there may be some NMS component may be there, but whatever they are given in the history, an MRI finding is favoring of a reversal cerebral vasoconstriction that is classically seen with your SSRIs and SNRIs. And 17-year-old female presenting with perioral sensation, bilateral upper limb tingling sensation, recurrent histories of perioral and a bilateral upper limb tingling. EEG was done during activation phase of EEG. They were doing some activation process in EEG. The symptoms were recreated but without EEG changes. What is the cause? The confusion between all three exists among the candidates: hyperventilation, spells, functional, sensory seizures. So first of all, take the sensory seizures. What is sensory seizure means? You have right and left cortex, and sensory seizure means it is from the, suppose I am having a sensory seizure from my right parietal lobe. So what will happen? I will have sensory symptoms on my left side of the body. It cannot be bilateral, it cannot be perioral. Perioral and bilateral upper limb means it should be spreading to the bilateral parietal. That is very unlikely. When the seizure spread bilateral cortex, patient will not have consciousness because it became generalized. Clear? So sensory seizure, according to the history semiology, it is not at all you will not think of a sensory seizure. This is not a classical presentation of sensory seizure. Sensory seizure is one side of the body you will see. That is clear. So then coming to the next options, there is an EEG taken. The event is triggered, but EEG shows normal. That means it is unlikely to be epileptic. That also tells you that it is unlikely to be epileptic. But sometimes in the deep-seated temporal lobe and all, you may not see any EEG changes. But when the patient had a ictal changes or a seizure during the event, you will see some slowing, at least a slowing or a fast activity. So there is nothing is there that tells you that it is not an ictal event. That also rules out your sensory seizures. So it should be either hyperventilation or functional. During the activation, you will do what are the mechanisms you will do activation of EEG. One is sleep is an activation process. Second is you will do a hyperventilation. And third is a photic response. These are three classical things you will do in EEG for activation, normal EEG. Any routine EEG you will do all these three things. So during hyperventilation, the patient might have shown this event. That tells you that the event was provoked by hyperventilation. The answer is hyperventilation spells. The next confusion the students was why it is not functional. See, the definition of functional neurological syndrome is different from hyperventilation spells. Hyperventilation spells may be part of a functional spectrum or a conversion disorder, but hyperventilation spells can also be triggered by the patient. Okay, can also be triggered for malingering by the patient. And it is a different entity. A functional is never means that it is malingering. Functional is actually a disease of neurological disease only. It is not a normal thing. Functional disorders are not malingering. It is not a normal thing. They are a disease only. Functional describe that the possibility that there is a functional change in the brain circuit, not a structural change. Understood? In the nervous system, there should be a functional change which you cannot make out by your imaging or any test available right now, but there is a functional change which is happening. There is no structural change. So functional neurology is a different thing where you get a PNES, paroxysmal, psychogenic non-epileptiform seizures, which they demonstrate like a seizure. That can be functional. But hyperventilation spells is somewhere in between. So among the options there should be a confusion, but I think the best answer is hyperventilation spells. Because functional, the definition is slightly different. So this is again ambiguous question. But I feel the answer is hyperventilation spells. So the definition of functional describes the broadest possibility and sense of problem due to change in function rather than structural. That means there is no structural defect, but there is a functional defect. Clear? So coming to the next question. This is actually one of the questions which asked from the muscle. Actually, I had been telling like LGMD, the naming and the protein. Every time one question is coming. Last time also one question came. So I told you to study the new name and all, but the question doesn't need such new name and all. The defective protein in LGMD 2A. That is a direct knowledge-based question. It is calpain 3, which we have discussed in our module as well as we discussed in the high yield series also. Like LGMD 2 is a calpainopathy, 2B is a dysferlinopathy, 2C is sarcoglycanopathies, and telithenopathies, proteinopathies. These all things we discussed in other other dystrophies in the muscle disease module. So LGMD 1 we have discussed mild tendinopathy, laminopathy, cavalopathy, HSP40, proteinopathy, all those things we have discussed. So LGMD 2A is calpainopathy. Okay, this is a repeat question. This is like from this area, one question every time they will come. You should always in any exam, whether it is a NEET or it is INI, you should go to this area. Induction therapy for cryptococcal meningitis. I don't know exactly what options was there. The induction therapy is actually a flucytosine with amphotericin B. Liposomal amphotericin is flucytosine as induction for HIV patients. And immunocompetence, it is amphotericin B plus flucytosine for 4 weeks. But in immunodeficient HIV, it is for 2 weeks. Then consolidation is the dose is given. We have discussed it in our infection, where we have discussed MCQs on infection. We have discussed about this. 2-3 questions we discussed about cryptococcal in the beginning only. You can watch that. So the answer is flucytosine plus amphotericin. I think there is one option on flucytosine plus amphotericin was there. I don't know the exact option, but that is where I explained the details. The answer is amphotericin B plus flucytosine for 2 weeks in immunodeficient and 4 weeks in immunocompetent is the induction phase. Then consolidation phase, you give fluconazole 800 milligram per day in HIV patient, while it is 400-800 milligram for 8 weeks in the case of normal patients. While in immunocompetent, a maintenance for about 1 year is given at 200 to 400, while in HIV patient, you continue it lifelong, and usually cryptococcus infection happened in a CD4 count of less than 100. That also we have discussed. So that is the induction therapy. It's again a straightforward question. There is nothing confusion in that. If you know, you can answer it. And HIV, there's a clinical scenario given HIV patient with the CSF showing presence of fungal spores and lymphocytosis. What is the diagnosis? I exactly didn't get the entire thread of the question. I think the question was framing for a cryptococcus meningitis. So there are 2 questions on cryptococcus meningitis. This question is again an interesting question, and there are some confusion in this question. This is actually not a pure neurology question. It has some infectious part also, because they are given black tar heroin. This black tar heroin is a crude form of heroin which looks brown or black in color, which is used for IV drug abuse and all. When they use this contains botulinum toxin. So you can have a botulism because of black tar heroin. And whenever you have black tar heroin, the first thing is botulism should come to your mind. So botulism can be a wound botulism, infant botulism, or to the food. Foodborne usually present GA symptoms and later neurological manifestation. IV or IV drug abuse is associated with the botulism. They classically present with the facial and pharyngeal weakness or bulbar weakness. So they present with facial paralysis and bulbar symptoms. So next DD is a GBS, pharyngobrachiocervical variant or some variant of GBS. GBS versus botulism. So the black tar heroin is a clue for that. If black tar heroin is not there, it can be GBS also. Then they are given a CSF report of 0 cells and 75 somewhere around 75 milligram per deciliter protein. This actually shows an albuminocytological association. And there are some students telling me that in Harrison it is given, if it is 100 is given as albuminocytological association. But in Harrison it is never mentioned albuminocytological association is 100. They are given is albuminocytological association raised to protein, usually bracket they are given 1 to 100. I mean 100 above. But Harrison is not the last word for everything. You understand that the concept of albuminocytological dissociation, rather than mugging up, what is albuminocytological dissociation tells you? That tells you that the protein is elevated when compared to cells. Usually when cells elevated, you will get some protein elevation as in infection or sometimes in traumatic trap. But here when the cells are not increasing and protein is elevating, that means that there is an inflammation happening in the CSF or happening in somewhere in the nervous system, in that area of the nervous system. So that tells you that it is not a typical finding in GBS. You can get albuminocytological dissociation in many conditions. GBS is one among that. So here also you can get a raised protein in botulism also. So that is why this protein is raised in this one. This also tells, it shows albuminocytological dissociation only. Always in GBS, botulism is a DD. Okay, botulism is something which causes descending paralysis of body. I told body, botulism, diphtheria, the body, tetanus. These are the 3 things which produce descending paralysis of body, start from above downwards. While ascending paralysis bodies produce many conditions, one among that is GBS. CDP, GBS, everything is starting the lower limb, goes upwards. So descending paralysis of the body, that is tetanus, botulism and diphtheria. So that type of starting with the pharyngeal and facial can also present in some variants of GBS. But here they are given black tar heroin, that tells the clue that this is not a GBS. The answer is botulism. Clear? That is actually a combined question of neurology as well as from infection, but that is a pure infection question in fact, because they are given particularly botulism, the classical presentation also. Only confusing thing was album dissociation. Just understand that dissociation can present even in many conditions. It tells you that there is an increased immune protection of protein. Okay. History suggestive dermatomyositis is given, and I don't know what is exact history, and I don't know which area or which rash they had shown. You can have a heliotropic rash around the eyes. That is more pathognomic. Heliotropic rash around the eyes. Then you have a butterfly rash around this area, around the cheeks. Then you have a shawl sign where you have over the posterior part of the neck where you wear the shawl. And the V sign in front of the neck. That is in front of the chest, anterior chest. Then you can have Gotton's papules and Gotton's sign. Gotton's sign is over the extensor aspect of the MCP joint or the knuckles, as well as in the extensor aspect of the elbow and sometimes the knee. You will see erythematous macular rashes. Then Gotton's papules are when these rashes become papules. The Gotton sign thing become papules, will call Gotton's papules. And mechanic hand mainly on the radial surface of your hand. Basically more on the index finger and the thumb, that area, hand and the palmar surface, you will see the mechanic hand. I remember that, I mean, from all the students, told it is heliotropic rash was given, that was around the eyes. Gotton's was there on the extensor aspect of the hand. Heliotropic, perioral, butterfly rash in the face, that is in the cheeks, shawl sign or V sign in the posterior neck and anterior neck is a V, posterior neck is a shawl sign. Gotton signs are macules, extensor knuckles, elbow and knee. Gotton's papules are when these macules become papules. Mechanic hand are not classical of dermatomyositis, but also seen in dermatomyositis. It is seen in, I discussed about it, particular antibody positivities in some of the inflammatory myopathy. The last question, which was treatment of Listeria meningitis in elderly male, is very simple, which we have discussed that in a patient up to 50 years of age, you will give a third generation cephalosporin plus vancomycin as a drug of choice or empirical therapy. Why? Because you want to cover Streptococcus pneumonia, you want to cover Neisseria meningitis and H influenza. These are three drugs, three bacteria you are planning to cover. In those immunodeficient or an old age, more than 50 years, alcoholic, nutritional deficiency, less than 2 years, you will think of another possibility of a Listeria also. Listeria you cover with ampicillin, that is 2 gram IV tube 4H is recommended. But remember, even though they are recommending cephalosporin plus vancomycin, majority of the patients, especially in India and particularly in South India, you can treat with only cephalosporin. Because pneumococcal resistance is much lesser. Even if you are not able to give vancomycin, like the patient is having a renal dysfunction, you can treat with ceftriaxone 2 gram also. Neonate, you give ampicillin, cephalosporin, gentamicin. 20 to 50 years, third gen cephalosporin is vancomycin. This is directly from our module. The slide is from the module. You can go and watch the module where I have discussed about all those things. So ampicillin is a drug of choice, Listeria meningitis, and 2 gram IV Q4H. And there was one question regarding substance P, which I didn't get the answer. So I mean, I didn't get any of the option because it was a huge question, but there was a question regarding substance P. So regarding substance P, I didn't get the options. It is a neuropeptide. It is a neuropeptide, which is related to neurokinin A family. And this substance P is involved with pain particularly. And pain to a slow pain that is mediated through fiber C. You have a fiber and C fiber. A delta fibers carries a fast pain. This carries a slow pain, or it carries a chronic pain. It has a role in inflammation, neurogenic inflammation. It has a role in vomiting and nausea, particularly when seen with pain, can sometimes trigger nausea, vomiting. That can be triggered with this. It also involved with some behavioral response, including mood, anxiety. It has been known to be associated with some learning and regeneration also. So all these are together the function of the substance P. And substance P is produce chronic pain. Substance P produce slow pain. Substance C act through fiber C, and they are located in the dorsal root ganglia. They are mainly located in the dorsal root ganglia. And because it's chronic pain and it is related to mood and anxiety, that is why many of the chronic pain patients will have anxiety or depression as a component. And that is why antidepressants act. It is one mechanism why how the antidepressants act in such pain also. And it causes neurogenic inflammation. It triggers nausea and vomiting. It causes some of the regenerative mechanism. It causes vasodilatation. So it has multiple mechanisms of action. Altogether, remember that substance P is a molecule. It is a neurotransmitter and neuromodulator released from the nerve, particularly dorsal root ganglia. it has some involved in the pathway. I think the option was regarding dorsal root ganglia and other areas. It is present mainly in the dorsal root ganglia. So this question I didn't get the entire options and answer. I tried to multiple sources, I didn't get exactly what was there. But the only thing what I can provide you is you just go and read about substance P, and particularly in relation to pain. These are the actions of substance P, and substance P is a neurokinin related peptide. So that was about the 28 questions which was asked in the NEET SS. And as I told initially, this paper is rather different from the last two sessions. But even if there are only very few clinical things, those clinical things were easy. The questions were not that tough, but they made you confused with few ambiguous questions, and they made you confused with the options. And from the entire review, what I want to tell you is that I didn't get the exact option. So there may be some difference in the options and question, but the areas are same and discussions are same. So this will be, I hope this will be fruitful for all those who are planning for the next NEET SS. And before planning NEET SS, make sure that watch all the recalls first. Okay. And like any time, this time also, like all other times, this time also a lot of questions came from neurology. Out of the entire questions, around 28 questions are from neuro, which is something which I got. It may go up to 30 also. So that was about the NEET SS 2023 recall. Thank you all for listening.